individuals for individuals with chronic or rare conditions, this transition is even more complex. They're navigating newfound independence, education, work, health insurance, especially after the age of 26, and transitions from pediatric to adult care. And AI is entering this healthcare environment at the same time these young people, these young adults are learning to manage their own health. So the intersection of this is what we're exploring today. So why this topic and why it's so sexy? Well, there's a lot of promise about AI, and recall that it's only been about 3 years since OpenAI came out and really, caused a lot of hype about what AI was going to do for healthcare. There is a lot of promise. There's a lot of potential to reduce the friction that we all experience in healthcare, both as medical professionals and as patients. It has the promise to streamline administrative tasks, surface timely information, support coordination, and improve engagement between visits. And for young adults, the 18 to 34 Gen Zers who already rely on digital tools and value their autonomy, AI can simplify complex health-related tasks if implemented responsibly. So, as I said, this really matters to young adults. The young adults, as I said, are digital natives. Let me go back. Are digital natives. They expect to have innovation and technology at their fingertips. They want immediacy, transparency, and tools that support them in their healthcare journey and for self-management. AI can also help them interpret medical information, manage appointments, increase autonomy. But if these systems are flawed, inaccurate, or biased, they risk eroding trust and worsening inequities. So 2 in 3 physicians are using health AI. This was in an AMA survey that was done in late 2024, reported this year. And the acceptance seems to grow day by day. And many review this as a way to reduce administrative burden and support decision-making, but it's sort of a mixed bag. And in fact, today there was a report, a physician survey released by an organization called Off Call, that confirmed that about 2/3 of physicians are using AI in their daily practice, with 84% saying that it made them better at their job. And I just accessed it about 5 minutes before I signed on, so I don't know the rest of the survey, but as you can see, the use by medical professionals is just growing day by day. However, physicians stress that AI tools must be trustworthy, validated, transparent, and seamlessly integrated into workflows. So how do patients view AI? Patient sentiment towards AI is far more cautious. And a lot of the surveys that are done by these big organizations like the Pew Research Center look at all age groups, all adults, and what their views are. And a recent Pew Research survey showed that 60% of Americans are uncomfortable with their provider relying on AI. While 40% believe that AI may reduce errors, many worry that AI may worsen care quality or depersonalize the relationship with their clinician. And it's a mixed bag, and it really varies based on what the use is for, how patients feel about it. There's also some emerging evidence in the medical literature about what patients feel, and it mirrors the Pew's findings. There really is low trust when it comes to physicians' use of AI. As you can see, that bottom line, patients express low trust in healthcare systems to use AI responsibly. 62% want to be notified whenever AI is used in their care. And they really don't expect it to improve the relationship with their doctor, improve affordability or access to care. So overall, the findings in many of these studies demonstrate that there's low trust. Now, this may be different for the Gen Z 18 to 34 age group, because as I said earlier, they expect to have these particular innovations. So what I tried to do for the sake of the roundtable, when we talk about these different systems and tools, I categorize them into three buckets. One of them is, the first bucket is direct to consumer type of applications and systems, basically for enhanced self-management and really things that patients can do on their own. And they're viewed as consumers by these companies. There's AI use in the clinical environment. And then there's the generative AI, the commercial AI tools like OpenAI, Anthropic, and so on. The direct consumer tools, excluding digital therapeutics categories, are not meant for diagnosing or for treating, and they tend not to be regulated in the same way that AI tools have to be if they're patient-facing in the clinical environment. And those systems in the clinical environment are called software as a medical device, and therefore have to be regulated by the FDA. And more, these are being integrated into the clinical environment. One of the most common tools that patients will encounter will be ambient AI scribes. Physicians overall really like these, so they don't have to spend their times with their face on the computer typing while they're talking to patients. The AI scribe documents the encounter and oftentimes organizes the particular note and summarizes the particular note. So that's an example of AI being used in the environment, but there's all kinds of other uses that patients may not even be aware of. There's AI-powered imaging interpretation. Your radiology studies are being interpreted through AI in a lot of institutions. Your cardiology tests are being interpreted, as well as in some places pathology, and the administrative tasks more and more increasingly are being completed through AI systems. So what can a patient expect across the healthcare encounter, the continuum? So there are tools and systems that are used in the preclinical phase of your encounter. There are tools for registration. There are chatbots that will send you reminders about your appointments. They'll do benefit checks prior to your visit, and there are tools that'll prep the clinician with summaries of a patient's history. During the visit, as I mentioned, there are ambient AI scribes, and there are also other tools that are used, algorithmic tools that help a physician with their decisions that they make during the visit. And after the visit, there are AI-powered tools that support billing, insurance claims, and so on. What I find interesting is the advent of agentic AI tools that autonomously plan, execute tasks that were once done by human beings. And so that's an interesting area that we may want to talk about, how young adults feel about that. So specifically to young adults with chronic conditions, those type of tools that do these particular functions, I think would be very helpful to reducing the friction in their care. So there's AI-supported referral and routing and appointment matching, which, for those who see multiple specialists, I think would be very helpful in smoothing out that. There's inboxes, which are annoying for physicians and patients. They could help triage messages, those that are more important that need to be viewed more quickly versus those that are more routine, and those that need to be escalated to a medical professional. And I think too, an area for those who need a lot of care, that there are tools that help not just the institutions with prior authorizations, but also patients as well. And I think we're going to see more and more of that, helping patients with claims that are denied and for prior authorizations. So now I want to turn to commercial apps. Let me just see if I get my talking points here. As imperfect as the commercial Gen AI systems are, most people are using them for information for their healthcare. They're going to ChatGPT, Anthropic, Perplexity, and all of those general commercial type apps. But there's a lot of issues with those particular apps. They are not large language models that are built on medical information, but rather they scrub the internet looking for information. So they could be looking at like Reddit boards, for example, and using wrong information or misinformation in order to answer certain questions. And it's unknown exactly where this information comes from on some of these commercial apps. And so a lot of caution needs to be had with using these particular apps. However, it's convenient and quick. They provide easy to understand answers to complex topics. It kind of feels private. You're doing it on your own home computer and or you're on your phone, so you do get information. And another thing that it does is it equalizes that information dynamic between medical professional and patient. So you can come to your visit and say, I was on ChatGPT and ChatGPT says, what do you think? And as I said, there could be a lot of inaccuracy and biases. It can have outdated or inappropriate information. It's really not that private. And so there are risks of harm. And so we need to encourage patients to be open about their use of these tools and to confer with a medical professional about this information. Now, some of what we're going to do is today is talk about mental health apps. And there are direct-to-consumer mental health-focused AI-powered applications. I'm sure there are a lot more than I've listed here. These are the ones that I could find. But this is a combination of chatbots specific for mental health. There's companions. And they do things like meditation, all the way to cognitive behavioral therapy. But they are not for diagnosing mental health conditions. They cannot provide medical advice or replace a live therapist. And they're not for people with severe mental health conditions or patients people, I should say, consumers who are in crisis. There are privacy concerns with these apps, and there probably needs to be a lot more studies for the safety and efficacy of these particular applications, but they can be helpful for coping, providing support, for mood tracking. But again, they don't substitute for mental health care. I bring up the use of mental health care with chatbots like OpenAI, and we've seen in the media, especially over the last few months, including last night on NBC News, about people that use these chatbots when they're going through struggles. And this is not they're not really good for that. And in fact, could be very harmful. And there have been reports of young people using these apps who have died by suicide or committed violent acts, allegedly due to encounters with these apps, where the apps allegedly, for example, told somebody in distress how they could commit suicide, how they could commit harm, where they could do it. And this has been shown in the medical literature, actually. I can cite one study that did simulations of people with using Chat GPT 4.0, where they demonstrated that it provided inappropriate responses to people in crises. So it's critical that these companies and that we continue to advocate that they place guardrails on these commercial systems and that medical professionals advise their patients to not use these systems for therapy or as companions. So, with regard to what matters to young adults, studies have shown, and I think we'll discuss, is that young patients want autonomy and control. They want clear communication. They want respect for their privacy. They want inclusive, human-centered design of their technology. And they do appreciate, reduction of administrative burden. I think they would expect interoperable or connected data between their different systems. And tools that fail to meet these expectations will really damage trust. There are concerns about equity and inclusion, and the AI has the potential to widen these gaps if they're not designed responsibly. Underrepresented groups may receive less accurate outputs, and those with rare diseases may be at particular risk due to limited data in the training of these particular systems. So ensuring equitable AI requires inclusive data sets, continuous evaluation, and intentional design. And design should be done with representation from the population served. So if these are applications or systems that are being sold to or designed for young people, then you need to have young people involved from the start, as well as on advisory committees. I think that is very, very important. And they should promote inclusivity. So designing for neurodiversity, people with low vision and hearing, low English proficiency, and health literacy. And lastly, inequities can occur when patients don't have access to devices, Wi-Fi, and quiet spaces for confidentiality. So other ethical considerations, which my partner Kenzie is going to go into more in depth, are critical. We must have transparency and informed consent. We must have data governance and privacy, safety, validation, and reliability. We must have accountability for outcomes, especially those commercial open AI and among others, with regard to how their systems are being used and misused. We must have protection from biases and build systems that support and not replace human care. And we must have disclosure and consent. So the key takeaways from my presentation is that AI has tremendous potential to reduce clinician burden and patient burden and increase access for young adults with chronic and rare conditions. Patient-facing AI must include transparency, informed consent, and strong safeguards, especially around recording and data use. And these are just some of the questions, and I'm sure you'll have others, that patients need to ask in the clinical environment about how AI is used using their data. And we need to design AI with and for young adults. It's essential to creating systems that are safe, trusted, equitable, and truly beneficial. So now I turn it over to my very intelligent and learned partner, Kenzie.
That was simply excellent. Dr. Adirim, thank you so much for everything that you shared. And as I share my screen, I would like to thank you all in advance for your grace, because in reflecting on my lived experience as a relatively new diagnosed chronic condition patient, I realized that a few bullet points ended up turning into what felt like an audit. So there are a lot of words on the page, and I want to acknowledge that a lot of words on a single slide isn't always as accessible as it should be, and to minimize the redundancy of some of my content, because Dr. Adirim uplifted some points in manners way better than I could. I'm just going to do a high level overview and then hopefully can articulate myself better in depth during the proceedings that are published shortly. So with that, I'll start yapping about something else. All right, let's go here. So, as I mentioned, this is a very subjective audit on the equity and ethics of emerging AI technologies. So I think it's so important to have a working definition of AI as well, because I think that AI has infiltrated our lives to the point where we might take for granted what is AI versus what isn't AI. But if someone asks you what is AI, it's hard to give a definition without using the term itself. So according to IBM, AI is technology that enables computers and machines to simulate human learning, comprehension, problem solving, decision making, creativity, and autonomy. And I put each of those components in boldface and underlining because those are the metrics that I used for my ethics and equity assessment that I'm leaning into today as I also reflect on my lived experience. And there are many different ways to stratify types of AI. You could do it based off of whether it is narrow minded or super intelligent, the speed by which it generates information. It could be based off of whether it has its own memory and is self-aware, but I think that the most practical approach to categorizing AI, and I'm really happy that this is in alignment with what Dr. Adirim did, was by functionality. So the 5 different types of AI that I understand are generative, predictive, assistive, conversational AI, and that's where we'll get a little bit more in depth in the mental health support implications of AI, and then autonomous AI. So before that, I think it's so important to ground myself in my positionality, my privileges, and my disadvantages in my approaches to evaluating things like AI. So I first became Sneha's internet friend in early 2020. And so I've been a longtime fangirl of Generation Patient, but I also found that as I was dealing with chronic pain, chronic fatigue, also on gentle content warning to binge eating disorder, severe anxiety that came with changes in my body composition. And as a result of my body image, I felt, okay, I'm not a young adult patient necessarily, but I find a lot of validation and visibility in this space. And I've been able to do some health equity facilitation and work for Generation Patient as a result. Full circle moment, January 10th, 2026, I was finally diagnosed after nearly 8 years of exploration with a textbook case of polycystic ovary syndrome. And I was diagnosed fewer than 5 months before I was turning 26, i.e., going to be booted off of my parents' employee sponsored health insurance, despite first lifting up this concern about possibly having PCOS, explicitly saying, I think I have PCOS when I was 18 years old, a sophomore in college at home feeling miserable. And what immediately came out of the nurse's mouth was like, you don't have PCOS. The reason why I was still underweight then. And PCOS is often associated with overweight or obesity, especially in women of color. And so I felt essentially I was typecasted. And so when I came to this reckoning, Generation Patient, my participation in Generation Patient took on new meaning for me. And so did AI, actually. I saw AI as an opportunity area to actively combat medical gaslighting by helping me to essentially get my thoughts together. So when I have 10 to 20 minutes with a clinician and their instinct is to be dismissive, I don't find myself speechless and stuttering. I can essentially serve as a patient self advocate. While the system in the interim figures out how to be a better advocate for me. And for those who are able to see me right now at this time, I'm also a Black woman. And so there's definitely nuance to my gendered and racialized experiences of how I feel the timeline and the cadence of my diagnostic process worked out. And so it's really important for me to do some personal and now out loud exploration of how AI can serve as a point of hurt and harm, and also retrospectively think about whether AI would have expedited or delayed my own nearly 8 year diagnostic process. So I also want to ground us in my goals in doing basically a subjective audit here. And as I said, it's to reflect on my own experiences, past, present, and future, but also scale them outwards to other young adult patients using the metrics of, again, human learning, comprehension, problem solving, decision making, creativity, and autonomy. Essentially, this AI as it currently stands and how it's being socially marketed live up to those frankly tall orders. And I'm grounding this assessment in ethics and equity because to me, at least logically, inclusion and learning how to be inclusive while also protecting people is a question of ethics and equity at the same time. So this is basically their meeting point. All right. So this is divided by the types of AI I described. And again, I'll probably only go through a couple points per each section, just out of respect for everyone's time. But again, IBM defines generative AI as deep learning models that can generate high quality text, images, other content based on the data they were trained on. So that's your Chat GPT, that's your Dolly. Full disclosure, all of the images that I created in this presentation were through Dolly on Canva. So I use a lot of constituent tools within OpenAI because they're commercial, they're accessible, they're free to an extent. And with that, one of the mainstream uses of AI for me is in social marketing and health communication. I'm a health educator, and it brings me so much joy when, for example, I'm teaching my students and I can generate an avatar that looks like them instead of a stock photo that does not look like them. That is how information sticks and resonates for them, and it can for us as well. It can also help with personalized treatment planning, reference-based claim pricing using electronic health records. So it can actually help payers to determine what proportion of someone's treatment they're going to cover. However, there are, of course, some heavy ethics and equity implications for YA patients, for young adult patients. For one, when you use electronic health records for reference-based claim pricing, it disproportionately negatively affects people who are uninsured or underinsured. It's also, and to that point, it's only as inclusive as the data on which it's been trained. And we'll talk about this a little bit more with predictive AI. But if you use Chat GPT, and I'll show you an example of my personal use of it, you'll notice that the suggestions that it gives, even like how to employ language in a doctor's office, is based off of specific ways of speaking, thinking, and knowing that have excluded women and non-binary people, people who are not white, uses language for people who are not wealthy. The average literacy level in the United States is about fifth grade, and I personally find that ChatGPT is not really accommodating of that. The terms and conditions for OpenAI are very small print, so at a very practical level, inaccessible, but also really hard to find and digest. So I'm really not sure what type of data is private of mine that I use to generate avatars, things like that. And sometimes when it comes to image generative AI, you can tell that it used some artistic license at the expense of accuracy because they know that people are attracted to pretty things. But that's how hallucinations in AI often come about as well. What's going to be appealing to the eye that might distract from someone thinking like, okay, can you give me a peer-reviewed source on that? So an opportunity area or a potential solution could be thinking about how to have generative AI tools that are fine-tuned to the specific data and concerns of marginalized groups. I don't know if you knew this, but Chat GPT has a variation on it called Chat Black GPT that draws from primarily Black historical data sources. And if you listen, if you actually do like the text to voice, like the voice sounds like Angela Bassett. And to me, that's healing because like a lot of my relatives sound like that. And so I'm more receptive to the information that it provides. So things like that matter. But of course, Chat Black GPT and thinking about the inclusion versus protection of marginalized, minoritized group dilemmas has a lot of ethical concerns that it needs to air out. So what would the timeline and practicality of like a chat patient GPT look like? All right, and so here are some image screenshots of a conversation that I had in late October with ChatGPT. My chronic pain and fatigue had kind of come to a head. I'd assumed it had to do with my PCOS, but then I was on the phone with an older cousin, and she said, our family has a history of Cushing syndrome. So why don't you try to explore whether this might be Cushing syndrome? And so I loved that ChatGPT basically helped me to distill down all of my scattered brain thoughts because I'm like, Cushing syndrome would be an extra variable that would just completely make me panic in my current treatment plan. And they told me how to discuss my concerns, specific questions to ask, and labs to consider requesting blood panels, and then ask specifically why a certain blood panel might not be ordered for me. So, of course, it was a very affirming process trying to complete my doctor visit prep sheet. But as a health educator, there were also some very strong concerns I had about ChatGPT's approach to addressing my Cushing syndrome anxieties, especially given the important context that I have PCOS and PCOS symptoms and Cushing syndrome symptoms significantly overlap in the Venn diagram to begin with. So here's what I think the prep sheet did well. As I mentioned, key topics to discuss with my clinician, specific tests that could be ordered, time, attention, validating language. A key takeaway that I have just from AI use in general is that it's not necessarily about the content or the accuracy of the content. It's about the packaging. It's the fact that it's not going to tell you, no, you don't have PCOS and look you up and down and judge you. It's going to listen to you. And that's why so many people are leaning into alternative medicine expertise because they really just want to be treated kindly. And sometimes being treated kindly then usurps actually being treated with competence. And that can be very dangerous, but something that I think clinicians should confront within themselves as well. To that, possible areas for improvement, acknowledgement of all the hidden variables that could come with the self-diagnosis. I might have, for example, like a hump in my back that I mentioned, and that is a big physical symptom of Cushing syndrome. But I'm also very stressed out, and I also have pelvic pain due to the PCOS, which causes me to hunch over. And that could lead to a fat deposit in my back that has absolutely nothing to do with the genetic components of Cushing syndrome. So, moral of the story, I don't have Cushing syndrome. All of this is like everything I'm going through is an offshoot of my PCOS diagnosis. And I was able to learn that by basically working through my doctor visit prep sheet alongside my clinician. And so the ability to more efficiently and effectively articulate myself was overall an enormous benefit. And it led my clinician, I mean, this is a problem in itself, but to see me as competent and prepared, and then therefore treat me with more dignity. I also want to say that as a generative AI tool, I've seen a lot of young adults actually use it as a conversational AI tool, as a chatbot. But I think it's so important for people to remember that as a generative AI tool, it's not trained to ask you follow-up or probing questions or consider, well, like, oh, do you happen to be a Black woman with this particular history, et cetera, et cetera. Chat GPT, for example, it's accessible, but it's not a social scientist meant to get into the social determinants of health. And also, it only responds to the data that you feed it and the tone of voice that you're using. So if you're someone who's prone to illness anxiety, then it's going to respond to the illness anxiety. It's not going to come alongside you to help mitigate discomfort or mitigate that anxiety. All right, so to that point, predictive AI, it can be used for emergency or disaster preparedness. It can also link patient risk factors to likely patient outcomes like hospital readmission, how much they're going to cost the system in the future. But it could also be used, actually, there was someone who recently won Forbes 30 under 30, and she basically was able to respond to older relatives' recent terminal cancer diagnosis, and that helped to determine essentially um, how they should compassionately care for that relative with the predicted amount of time that that person has left. So there are major equity and ethics implications for this as well as with anything that claims to anticipate or forecast, there is an imperfection. They, as models, they're not meant to actually tell you the future, but equip you with tools to deal with a likely future. But in doing that, it doesn't necessarily respond to how human beings operate in fear, and they can take prediction as prescription. And so I think that creators of predictive AI models need to be as transparent as possible in communicating its actual purpose and how it should be interpreted by the layperson. Also, I would be remiss if I didn't mention that predictive AI can be used for diagnostics, but there are lots of diagnostic tools still out there that have race adjustments, that have age adjustments, and that have gender adjustments that have since been proven to be very untrue. One example, especially for the patients out there who might have kidney challenges, is the glomerular filtration rate is adjusted for race so that African Americans are seen as having higher kidney function naturally, biologically, than other people. And that's why so many Black people will be on organ donation wait lists for up to years longer than other patients, which could lead to a full life of dialysis or even passing away before they're able to get an organ. And also, Black organ donors might give their kidney, and because of this GFR formula that predictive AI then uses to give recommendations, their kidney could literally be thrown away after it's taken out of their body. I'd be happy to share like the recent news story on that. Opportunity areas, potential solutions. Upholding a standard of having what I think of as like integrated predictive AI tools that use descriptive analytics that take historical context to let people know how we've gotten to this current state of disease and health disparities, but then also prescriptive analytics so that when they say, okay, we've got to prepare for this pandemic or we've got to prepare for this healthcare cost on this person, they actually include recommendations on how to mitigate that cost. I think it's a huge ethical question across the board of if it's the problem raiser's ethical responsibility to then propose solutions instead of leaving people to sit in fear and discouragement. All right, now assistive AI. And for this, I really want to elaborate on the use of mental health chatbots. So, of course, assistive AI can help with workflow automation. You might have engaged with a chatbot, for example, with IT management, which means that it's usually available 24/7, unlike humans are. And that can be incredible when you're working, for example, across time zones. It also helps to address and overcome language barriers. One of my favorite uses of assistive AI is personalized learning pathways for students who might benefit from academic accommodations. AI is used in like Zoom, for example, to summarize meetings, closed captioning, voice to text recognition. And it can go all the way up to tailored prosthetics or helping people, for example, with MS gain their mobility again. So assistive AI, I'd say, is probably the most versatile and expansive functional category. But with it being the most expansive and functional, I think that I have the most concerns about the ethics and equity of assistive AI. So, speech focused innovations from screen readers, recognition to augmentative and alternative communication devices, which can help translate people who might have, for example, speech impediments, words into sentences on the page, may still not prioritize nuances in vernacular accents, and also might not pick up on every cultural generational reference that might have subliminal messaging. It takes things very literally, and that can cause harm to people who might try to talk around what's really going on or what they really need, because it's hard to really say it in explicit terms. Also, when you think about personalized learning pathways and mobility and intellectual ability accommodations, right now they're really expensive. Not everyone can access them. So as people are pushing out patents and stuff, these things still cost tens, if not hundreds of thousands of dollars. So a big opportunity area I feel for assistive AI is actually targeted advocacy for assistive AI technologies to be included in health insurance coverage, but also funded, for example, by the Department of Education, so that young people who might have IEPs, individualized education program plans, have direct access to these assistive AI technologies so that they can academically thrive just as much as their counterparts. All right. Oh, conversational AI. So I'm actually going to go straight to the ethics and equity implications for this one. And as I said, I'm going to focus on mental health um, chatbots. But the thing about a lot of conversational AI is that it's socially marketed in ways that suggest it's a true alternative to actual real life companionship. And so, in the world of conversational AI, there's a relatively small proportion of conversational AI tools that actually say, you know what? Why don't you call that person that you're telling me about instead of me trying to give you just advice on how to avoid them or whether you were in the right or you were in the wrong. It doesn't really promote pro-sociality by design. And I want to also lift up that not everyone with a chronic condition can like go outside in the literal sense of the word to interact with people, but even just like encouraging digital engagement with communities is, I think, an opportunity gap within conversational AI. As I said, with assistive AI, when there are lexical gaps or there's stigmas surrounding specific physical or mental health conditions that people kind of talk around in chatbots, then chatbots don't have translational accuracy. They'll take it literally, and it could lead to confusion, it could lead to harm. And one primary example of that is that it's actually quite easy. I didn't include a personal demonstration of this because of the sensitivity of it, but it's actually fairly easy to override the automated detection systems for self-harm or suicidal ideation and mental health chatbots just by using loophole language. Instead of outright saying, like, could you help me do this to myself or someone else? You could really say, like, if I were considering this, what sources could I draw from to make this happen? And that it will literally give you links to how to conduct self-harm. This is true. I've tried it. And recommendations for self-care and recovery, they can be very, very ableist, and they might not include actionable steps to young adult patients. So the same way clinicians, or if you go to the Mayo Clinic or Cleveland Clinic website, they'll be like, lose weight, eat better food. It doesn't consider the realities of food scarcity, limits to mobility, all of those social determinants of health. And so, basically, the biggest opportunity area, I think, for conversational AI is modules on AI companionship, how to use it responsibly, protect yourself, and have digital literacy needs to be folded into health education curricula, basically at every level of academic access and potential achievement. Now, last but not least, I'm almost done babbling, I promise. There's agentic AI, and for me, this is almost the more convoluted type of functional AI, just because the technologies for this are still very much emerging. But basically, they do a lot of what predictive and assistive AI does, to my personal understanding, but they use real-time data and they require minimal human supervision. It doesn't need a lot of oversight. And so basically, it acts as a personal assistant that doesn't need directives. And so, especially for clinicians, I could see how that could be a dream come true. But getting specifically into the equity implications, I could see this being a potential replacement for human employees in medical assistant roles, community health workers, case and social workers, patient navigators and educators. Autonomous slash agentic AI is meant to do this work like post-op follow-up and redirection of resources. So yes, it improves efficiency, but it improves efficiency in doing roles that often are like gendered and racialized. As a former community health worker, I worked with like entirely other women, and about 80% of them were women of color. That can have major quality of life implications for people who are going to be quote unquote replaced for the benefit of like corporations that want to be more efficient. And then, of course, real time data, just like data that might be drawn from Reddit, peer reviewed publications, can only be as representative as the data it's trained on and the data that are out there. And currently, data are not as inclusive as they could be. And so, to echo Dr. Adirim, co-design, I think, is the most important step that can be taken as we move towards AI that is fed human commands to AI that assumes human commands. What does it mean to train people for to have autonomous AI colleagues? Does that sound scary to you, or does that sound promising to you? And what does that workload and workflow integration actually look like? So, key takeaways once again, I'm not going to read or cover all of these, but I think it's really important to raise that even as a health educator and someone who considers herself fairly health literate and privileged as a PhD student, I hate going to the doctor now because of my journey. So, technological advancement, like all forms of progress, can only move at the speed of trust. AI should be used as a facilitator of trust. And I do think that clinicians could learn from like the tonal echoing of generative AI. AI innovation should not outpace efforts to gather and diversify representative data for the AI to be trained on. Representative data should come first. AI that uses that data should come second. Something that I also noticed is that many AI tools were built on a vision of making systems more efficient and basically seeing like conflating risk management and workflow burden with human to human interaction. Like interacting, like a human interacting with another human is treated as an inconvenience and justifying a lot of AI development. And as we continue to live in a loneliness and isolation epidemic, we should think about whether that association is even useful in like the AI technologies that we're building. Um, to echo Dr. Adirim, opt-out consent options will not be good enough anymore. They never were to begin with. To take a different spin on it. Personally, I am a little bit reticent to use a lot of AI because I know of its environmental impacts. Every time I send a chat GPT query, I know it uses X gallons of water that are then going to be impact the climate crisis in places that don't even have access to AI right now. That's another inequity for another roundtable. Knowing what I'm complicit in addition to how my data is being used in AI, is an important component of consent. And of course, co-design should be the standard, not the exception. So thank you all so much. And I'm happy to elaborate during this discourse, but I'm most excited to hear you all's thoughts and lived experiences to be lifted up as well.